The news flying through the headlines these days can be pretty confusing, and it's never been more difficult to figure out who to trust or what to trust. So we started a new podcast to dig into the tough trending issues, add some data, and hopefully help everyday people like us actually to navigate these complicated topics. Today we're going to focus in on a big question. How are vaccine recommendations made, and can we trust them? I'm Sharon Kardia. I'm a faculty member in the School of Public Health at the University of Michigan, and we're very lucky to have an expert here, Emily Martin, who is also a faculty member in our great Department of Epidemiology. So welcome, Emily. To start, maybe you could tell us just a little bit about your background so that people know kind of what you're bringing to the conversation.
Absolutely. So I am a professor in the epidemiology department. And part of my research portfolio is that I work with various funders and government partners to monitor the effectiveness of vaccines on a day-to-day basis as they're being used by the general public. This is after they're approved, after they're already in the population. We're paying attention to who uses them and how well they're working and whether any adjustments need to be made. To that I've been working on vaccines since I first started grad school in 2003. I've worked on everything from monitoring vaccines out in the community to working on randomized controlled trials of new formulations. And I've sort of worked the whole gamut of different diseases that we've had vaccines for. And so in the most recent years, I've focused on respiratory diseases, flu, RSV, COVID mostly. But I've kind of had experience all over.
Wonderful, wonderful. So there's been a lot going on. The CDC director has been fired, asked to resign. There's been movement in the advisory committee, people asked to leave. So can you just take a step back and tell us about the process of vaccine sort of, I'll call it recommendation making? Like who does it? How is it typically done? And what are they doing?
Right. So sort of the before we got where we are now. The way it typically works, I think, I'm going to use an example of the influenza vaccine because everybody's sort of familiar with those recommendations moving and changing. So the process starts for the influenza vaccine with the WHO strain selection meeting. So they get in all sorts of samples and data from various countries around the world. They all get sent to the World Health Organization. And so then at the World Health Organization, they have a meeting with parties from countries all over and from scientists. They sit down, they look at it, they make recommendations about what to put in the influenza vaccine next year. They actually do it twice a year, technically. They do it once for the Northern Hemisphere and once for the Southern Hemisphere because we don't line up between the two. Yep. So once they make that recommendation, each country goes to their own process. They bring the recommendation to their own country and implement it. So here in the US, we first go to the FDA, the Food and Drug Administration. So they regulate what vaccines are available in the first place under the standard of they need to be safe and effective before they leave the FDA recommendation. So after the FDA reviews everything, then they are going to send that to what's called the ACIP, which is the Advisory Committee on Immunization Practices. So this is a committee that is formed by the CDC, but it's not people that work for the CDC. They actually are physicians and scientists in their own right, running their own, seeing patients in their own practice. So they're invited. It's a committee. It's actually, we can talk more about what goes into that committee. But they are in charge of reviewing all of the data again after it's come out of the FDA review to decide the specifics of the recommendation. So exactly who should be receiving the vaccine, how often, and when. And so that meeting then produces what we call, like, this vaccine has now been recommended, comes out of there. So the FDA decides, is a vaccine safe and effective? Is it okay to administer to people in the United States? The ACIP is going to then say who should be getting it and when should they be getting it and why.
Okay, that's amazing. All right, so I know it's difficult to kind of predict any kind of future for right now, but you've got experience with, how does this process and what kind of data are they looking at?
Yeah.
So before we actually get to some of the data that you shared with us, can you tell us a little bit about this concept of vaccine effectiveness?
Yeah.
Because it seems like it's like, oh, well, it's effective, but what does that actually mean?
Yeah, absolutely. So, vaccine effectiveness. So, I think people have sort of seen this in the news. I think after COVID, people are much more used to seeing these numbers. And they're usually expressed in terms of percentages. So the flu vaccine, you may say this, the flu vaccine is 60% effective this year. It's the COVID vaccine started out being 90 some percent effective. Now the estimates are somewhere around the 50% effective. And we can talk more
Mhm.
about why that has changed over time. But the way that it's measured, what that number means is that if you take the amount of disease that would normally happen in a given year, in a given population, that percentage is the amount that you cut it back by. So if a flu vaccine, say it's a year where the vaccine was mismatched, the flu strain changed too quickly for the vaccine to
To
keep
get
up
it.
with it. Yep. So say the vaccine effectiveness is something as low as 30%. That means the amount of flu you would have in a school or in a city
Is
is
reduced.
30% less if they're all vaccinated compared to if they had not been vaccinated. And it's a tricky number because people hear 50% and they think, oh, coin toss. That's not what it means. It means 50%,
Yeah, yeah, yeah.
half as much disease is happening than if you had not had the vaccine in that community. And
Okay.
so, yeah, and the way that we measure it, it can be measured the very first time a vaccine is created for a disease, the very first time we vaccinate against a disease, then you will have a trial that'll measure it. But after that, ethically, we keep giving the vaccines and we're monitoring all the time how it's working. Now, with a lot of the viruses, what that means is and this is something we do at U of M, something that's done all over the country, is we meet patients as they come into the doctor's office. We say, oh, looks like you have a cough. Let me find out if you were vaccinated or not. And can I find out if you can put a swab in your nose and find out if you have flu or not? And that gives a really clear answer
Yes or no?
on whether the people who are vaccinated are getting flu more or less than the people that weren't vaccinated. So that's the kind of data that we produce throughout the year.
And do you
Um,
submit that kind of data
Yep, it goes to the CDC every other week.
every other week?
Every other
Wow.
week. And when we do it for the respiratory virus vaccines, it goes every other week. And they then compile the estimates from all over the country, and then they're just constantly watching. And also, they're watching to see early signals if there's a issue with the vaccine that we need to intervene on. But then they're also watching just to make sure that the data is high quality and it's being verified and there aren't errors coming through the system.
That is awesome. Okay, so we've got some data from
Yeah.
some studies that you've got, that you've done. I think it was published in 2017, but actually there's a whole big story that is very relevant to today and
Yes.
how
Yeah.
people sort of think through that. So if we could maybe pull that up. One
Okay.
of the things
Yeah.
that I liked about this particular graph is that it has this breakdown by the subgroups of people,
Yes.
right? Because
Yes.
people want to know, like, for them, is this
Yeah.
going to work, right? And the idea that you actually looked in all of these different subgroups and you looked at different virus subtypes, because people know there's different viruses going
Yeah.
around. So maybe just sort of walk us through, like, the cases in the patients, the vaccine types, and then what do you see here?
I can absolutely do that. Before we do that, I'm going to tell you a fun fact
Okay.
that because the US Flu VE network, which produces data, is in a number of states all over the country, many of these reports, when they come out each year, you can look to see where, you also get to see where, the site.
Oh,
And so
wow.
people in Michigan can
Wow.
look and see, in Michigan, this is how effective the flu vaccine was for the monitoring that we did for our area, for Southeast Michigan. So it is hyper-personal data.
That
Yeah.
is amazing.
Yeah,
So
it's very cool.
would it be possible for us to link this podcast to that data so people could see?
Yeah. Yep, we can show those.
We should definitely do that. We
Yep.
should definitely do that.
Yep.
Okay.
So this is a study. This was happening. So some background context. The nasal flu vaccine, the one that gets squirted in the nose.
Flu mist is what it
Flu
used to be. Yep.
Yep. And so that had been on the market for a little while. And there was some debate as to whether we could find out not just the broad question of does the flu vaccine work, yes or no, but now that there are different types, some get injected, some get shot up the nose, some get produced in cells, some get produced in eggs. Can we start asking questions about specific types of vaccine? Does the way it's administered, does that matter? And manufactured by different places and all that. So this is data that came from the US Flu VE network. So this is coming out of that structure I just described all over the country. People are swabbing the noses of people with a cough that come to the doctor. And you've got different groups. So we've got all the way to the left listed the different categories that we asked this question in. In the middle, we've got the numbers of people in each of these different categories. And so it's communicated in a percentage, but you've got the number of case patients or people with flu out of the total number of patients that got their noses swabbed. And as you see, those numbers are in the hundreds. Overall, we've got over 6,000 people that were swabbed in this year alone. And then 1,309 of them had flu. So as we go through the different categories, they're all going to be in the 800. The 800s are sort of the lowest, smallest group that we're looking. So these are giant groups of people. And what this figure is showing, if you go all the way to the right, so you can see we've got a scale of vaccine effectiveness on the bottom. It's going all the way from negative 50% on the very lowest end, and the very highest end is 75%. And then where that dotted line is, that's 0. That's basically the vaccinated group and the unvaccinated group are performing the same if you're right at that 0. So you want your vaccines to be to the right of that line.
You want them to be effective.
Right? You want your vaccines
in the plus column.
to be all the way to the right. And then, so we've got dots for each of these subgroups in terms of how well the vaccine was working in each of these subgroups, communicated in a percent. And then we've got lines on either side that talk about how uncertain our estimate is.
So it could be in that whole range.
Yeah, exactly. The longer a line is, it's like, oh, we're really not sure where it's landing, but this is about where the middle is of our estimates. So most of these dots are falling around the 50% range. So as we talked about, 50% means out of everybody 6 months to 8 years that would have gotten the flu, it's 51% less in the ones that got the vaccine.
That's not bad.
So it's a big reduction, especially if you think about, it changes year by year, but so many people get the flu every year. So that's actually, in terms of actually numbers, it's a lot. It's a lot.
Yep.
You can fill football stadiums with the number of people that aren't getting the flu or aren't going to the hospital. So the 50-year-olds to 64-year-olds it's a little bit lower.
26% is a little bit low.
But it's still, if you think about how many of those people, we're talking working adults, how many of those people do get the flu, it's a pretty big absolute number. And also when somebody who's 50 to 64-year-old gets the flu, it means they are not picking up their kid from school on time. They're not going to be able to go to work. It is very expensive from a productivity standpoint. So we are looking at, you could look at in terms of different viruses, right? So is it specifically preventing the H1N1 strain? Everybody knows about virus strains now since COVID. Everybody knows
Except
that
some of these I didn't know, the Victoria or the Yamagata.
H3N2, that's a really tricky one. That one is a really hard virus to make a vaccine too. So we spend a lot of effort monitoring that one. And then B Victoria and B Yamagata. So when you've got a quadrivalent flu vaccine, we call it, it's got those four. Another fun fact for you, B Yamagata has not been seen since before the pandemic. Yep. We may have accidentally eradicated B Yamagata. And so now a lot of flu vaccines will only have 3 strains because the B Yamagata.
So trivalent, okay.
Yep. So then we go into vaccine type. And this is where the conversation really gets started, because we've got any influenza vaccine. So any influenza vaccine that's injected, the IIV, which is an inactivated influenza vaccine, which is what that stands for.
I was wondering about that.
Yep. And so that's just the shot that you get. And those are 51% for any. It's 41% for an inactivated influenza vaccine with 3 strains in it. And it's 54% for an inactivated influenza vaccine with 4 strains in it. But the live attenuated vaccine, the one that gets squirted in your nose, this year,
Tanked.
4%.
It's not worth it.
The line is so, the uncertainty is so broad. It is that, now this is that, like the people that were vaccinated were doing this, they were looking the same as the people that were unvaccinated.
So when that kind of data goes to this advisory committee, what do they do?
Well, first, I mean, the advisory committee that meeting was the culmination of a lot of meetings before that.
Okay.
Right?
Okay.
So first, we at the CDC and the partners were all like going through the data, curating it, verifying it.
Making sure it's right.
We, often will do double analyses. Like one group will analyze their data and then a second group will independently analyze the data to see if we get the same answer, do all sorts of things to make sure that we were sure. And then that goes to a working group. So a working group is this larger panel of scientists and experts on a certain topic. For this topic, it would be influenza vaccine. And then they make a recommendation to ACAP. ACIP saw this and said, no. Right? And so they actually they changed the recommendation to say for the following year, they were only recommending IIV. They were no longer recommending LAIV. It doesn't mean it wasn't FDA approved, but it was no longer recommended.
Because it was no longer effective.
Because they're seeing very clearly this signal that it didn't work in the prior year.
So what does the flu mist people do?
So they actually went back and worked more on that vaccine, and they came back. Okay. And they had, the flu vaccine is so tricky because it has to be updated and updated and updated.
Right, every flu season is different.
Right. And so the prior update hadn't worked. And so they made some changes.
Yep.
And then they went back, everyone reviewed them all the way through the process. And now they're back on the recommendation.
Great. So today's world is a little different. And you talked about the sort of the traditional way things are done. What do you think is happening today? Are you thinking that it's the same process, or that they might change their process, or the data's still out there? So, we've got in the news, the states like California and Oregon and Washington are thinking about making their own recommendations. And is that because the data is public and people can, like the states could make their own recommendations?
Yeah, I think the way that I think about it is that the skeleton is the same skeleton that we had last year. After this podcast, I'm going to go upstairs and meet with my team that is getting ready to go around and swab noses and find out who has a cough and who is vaccine and to calculate an estimate. All of this work that was put in place to make sure that vaccines are working and they're safe, all that work is still happening every day around the US and around other countries. Wow. So the job of our current setup in the midst of all these changes is, are they going to use that skeleton? Like, are they going to use that foundation and that infrastructure that's already there? And all of this data not only does this data get put out publicly, as soon as it's ready to go out publicly, but it also, everything that the ACAP and the FDA committee that approves vaccines, everything that they use to deliberate was being put on the internet ahead of time, weeks ahead of time. So we actually would have time to look to see what they were going to review and say, there's this other case that I don't see on here that's interesting, or hey, can you look at this, whatever. And so, it's not, I've gone to the public comment session. I've spoken, other people have spoken. It's not uncommon for even other scientists to weigh in during the review
comment.
process. It's not a closed process, it's an open process, because we're all sharing data. We're, as a scientific community, all kind of discussing what they're doing.
That's amazing. All right, so I didn't know it was that open.
Oh, we watch these meetings like other people watch sports.
I knew that was coming. I knew that was coming.
I mean, 'cause the deliberations.
There's a tight end and there's a quarterback.
Yeah,
and
I think what's also, so the U.S. system is really considered the gold standard internationally, and one of the reasons is because the deliberations are televised, or they're streamed.
Where are they televised?
They're streamed online.
Okay.
And sometimes they're on C-SPAN.
C-SPAN.
And you can watch not just the final decision, you watch them deliberate, you watch them debate and ask each other questions and challenge each other and disagree with each other and come to consensus or not. I mean, you watch all of this play out. It takes days, but you can see everything as it goes through the process.
Do you think that's going to happen this year too?
Well,
or has it gotten a little bit wilder?
There have been major changes that have not had an open deliberation that happened before the change. I've also noticed a big reduction in the availability of public comment periods and the ability to access those periods the way that we've had in the past.
That's unfortunate, because it sounds like it actually was something where sort of the raising of awareness and the participation of scientists and physicians and people that actually are invested in making sure that the vaccines are effective, kind of getting like a little bit pushed out of the process, which is, it's unfortunate. So amazing information, Emily. Thank you so much. I really, really appreciate this. Is there any last things or sort of, I'll call it wishes or bright spots that you would want for this upcoming year, in terms of people that are thinking about getting a vaccine? Just, is it just like, go get it? Or if the data is good, look at it first and then go get it? I mean, what would you say to an everyday person?
The data has been consistent. And so we know that the respiratory virus vaccines consistently the last few years, we know that they're reducing infections, they're reducing diseases. All of our data that we've either produced ourselves or with other people, it's all available online, publicly available. You can see those reductions. There's nothing, to suspect that it's going to be a wild year out of pocket. So the vaccine should work as expected. And there's new options this year. There is now an option where there is a vaccine you can administer at home with you get a prescription.
Wow.
You take it home with you. You can do it at home. You can, and there are lots of new ways of making flu vaccines as well that are it makes them able to be really responsive as the virus changes. The vaccine can change in tandem with it. So we're excited about those things. So I think it's going to be a good vaccine year. And, whatever the powers that be decide to do, we'll still be here.
Still collecting the data.
We're still going to be here measuring it. So.
All right. I just want to say a great big thanks to you, Emily. And for everyone that's listening, I would say next time you hear something wild, dig into the data, maybe look for the public data on vaccines, because it seems like there's a lot out there. And, it's always good to ask for the evidence. Take care.